Thank you. It's really an honor to be here today. My father actually grew up in Sioux City, and both he and his brother attended the University of Iowa. And so I was raised with a deep and abiding faith that really any significant achievement over the past 100 years that has benefited the human race somehow originated either in the state of Iowa or at this institution. I am honored to be here, but it is also a great responsibility. And I'm glad Dr. Lampier's presentation was so full of the opportunities that this bill presents us with, because as I was going through my presentation, preparing today, I realized, geez, this really is a little bit pessimistic and is really highlighting some of the risks and some of the challenges that are before us as we do this. It's probably not surprising. I work with insurance regulators, and insurance is all about managing risk. But I just want to say at the outset that I don't mean to be too pessimistic, but there are some challenges that I think we need to keep our eye on. But first, a few of the opportunities. I think this is a state-based legislation. That was one of the big debates as Congress was looking at the law and what they were going to pass. Would it be predominantly a national system, which is the direction the House was going in, or would it be more state-based? And they ended up with the more state-based system in the Senate bill, which I think is good because last time I checked, Iowa is not Massachusetts, Iowa is not Utah. This legislation provides the flexibility for each state to adapt what they do to all of the variations between the states in labor markets, demographics, delivery systems, insurance markets, and so on and so on. So I think that was an important decision that Congress made and really will, I think, make this a better product in the end. Dr. Lampier also touched on all of the ways in which this legislation will make the system a fairer system. There will be no more rescissions. No more pre-existing condition exclusions. All of these things will make insurance much more consumer-friendly in the future, but they are not without their risks. In the past, when states have attempted to put some of these reforms into place, it's resulted in adverse selection, which has driven up premiums for all individuals in the market. This bill takes some important steps to try and mitigate that. And that's something we're going to have to keep our eyes on. It also reduces the fragmentation of the insurance markets, especially in the individual market. In most states, carriers can have numerous pools into which they place individual policyholders and policy forms. And this segments the market and makes it much more difficult from a regulatory standpoint to manage. This legislation starts putting those pieces back together, and I think will make the insurance markets much more manageable from a regulatory point of view in that sense. And I think most importantly, it begins the process of addressing costs, the underlying costs in the healthcare delivery system. Today we spend in excess of $7,000 for every man, woman, and child in this country on healthcare, and it's rapidly becoming so expensive that no one can afford to pay for it. So this legislation begins the process of addressing that while also improving quality. Now the challenge there is it only begins addressing costs. Most of these are pilot programs that will have to be evaluated and then scaled up to the entire market. But that is, I think, at this point, the best we can do. There's still a lot we need to learn about how to implement all of these various changes. So Dr. Lampier talked quite a bit about some of the changes. This is the timeline over the next several years as to how these things will go into effect. We've already had the temporary high-risk pools begin accepting applications and a temporary reinsurance program for the early retirees. Now, the immediate reforms in the insurance market, those will go into effect with plan years that begin September 23rd. That's 65 days from today. That's not a lot of time. We have most of the federal regulations for these immediate reforms. There are just a few that we're still waiting on for internal and external review of claims denials and for the review of premium increases. And we're hopeful that those will come shortly. Beginning January 1st of next year, the medical loss ratio provisions will go into effect. And that is something that we are working on very hard at the NAIC. The legislation charges us with developing some standard definitions and methodologies for calculating that medical loss ratio, which we hope to have done by the end of the summer. Now, as far as these immediate reforms are concerned, just to give you an idea of how challenging the timeline is here, we all thought this legislation was going to pass in November of last year. That means that HHS could develop the regulations in time for state legislatures to address these issues in this legislative year in 2010 and have laws on the books in time for these immediate reforms to go into effect. As you all know, the legislation didn't pass until March, and by the time we got a sense as to what exactly would be required, most state legislatures are out of session, and it was too late to do anything in this legislative year to do that. So that raises the question of will the states be able to implement and enforce these requirements that are going into effect in September of this year. This legislation borrows essentially from the Health Insurance Portability and Accountability Act, or HIPAA, a preemption standard that basically states that any state law that does not prevent the application of the federal law will remain in effect. And the federal government will enforce provisions if the state does not. So if the state determines it cannot enforce a provision or decides it will not enforce a provision or implement a program, as we've seen with some of the states in the high-risk pools, then the federal government will step in and do that. In the case of the immediate implementation issues, the restrictions on rescissions and all of the other changes that go into effect just 2 months from now, we've looked at the state laws, and probably about half of the states believe they have the ability and the flexibility in their law to enforce federal law, the federal law, without changes to the state law. Now, for the remainder of the states, what will happen, I think, is yet to be determined. I think in many cases the insurers will just go ahead and implement the federal requirements, but we cannot count on that. And states will have to work with the federal government in order to make sure that these provisions are enforced. That may include states attempting to enforce the legislation and hoping they don't get sued by the insurers, or making referrals to the federal government when they detect violations of the new federal law for federal enforcement. At this point, it's also an open question as to whether HHS will be able to enforce these immediately. They're still staffing up their new office that will be implementing this, so they are not fully operational yet. They do not have the capacity to review the rates and the forms that insurers will be submitting in the near term. So this is going to have to be a partnership between the states and the federal government going forward. Another challenge with the timeline is a political challenge. We all know about the lawsuits, but also bear in mind that there are probably 25 or so governors who will not be here next year. So there's going to be a significant turnover in state administrations. That means that in the very near term, states have to get a lot of the implementation work at least started and a good foundation set going forward, because when those new governors take over, especially if there's a shift in party control of the governorship, then it is going to be some time before the new administrations are up and running and are able to take on this really momentous challenge that lays before them. In addition, states have strained finances, as I'm sure you are all aware. There are some insurance departments that are only operating 4 days a week in some states, and attempting to carry out their day-to-day operations as well as implement this new law really is going to be a challenge going forward. One of the key things to keep our eye on will be managing adverse selection in the market. One of the key reforms will be to reduce the variation in insurance premiums from prohibiting the use of health status in setting premiums and limiting the extent to which age can be used in setting those premiums to a 3-to-1 maximum. Just to give you a sense of where the states are today, this is the small group market, and it shows the total variation that's allowed in the markets. What you see in Washington and Oregon and much of the Northeast, those blue shades is where we're going. That's adjusted community rating. And the picture is even more stark in the individual market. That vast swath of gray across the country are states where there is no formal rating structure, and the only test that is applied to premiums is whether they're actuarially justified, whether the premiums bear a relationship to the risk of each of the factors that are applied. And this is where we're going. That's a big change, especially in all of those gray states. So what we are recommending is that a lot of states begin now, especially if they're gray states, to begin phasing this in so it doesn't hit everyone on January 1st of 2014 and cause what is called premium shock. And the danger is this: if you have a premium range for a policy, this is just out of thin air, say between $100 and $500 based on age, health status, and various other factors. If that's the actuarially justified rate, and then you compress that and say that you can't have as much variation in the market, it's going to bring down premiums for these older, sicker individuals, but it will also raise premiums for younger and healthier individuals. And guess who the regulators are going to hear from? The younger, healthier individuals whose premiums are going up. Now, if those individuals decide it's no longer worth it to purchase insurance, then they will drop out of the market and premiums will rise for everyone. That's something we very much want to avoid going forward. Unfortunately, the legislation does some things to help mitigate that risk. Provides subsidies for low-income individuals and an individual mandate, the penalty for which is phased in over a period of 3 years, which is a tax penalty, which is a percentage of income with also a minimum amount. Now, $695 per adult, or 2.5% of household income, seems like a lot of money, but when we look at that in comparison with the premiums that CBO has projected, we will see in the exchanges, I think it's still an open question as to how effective this individual mandate will be. That's something that states are going to have to very much keep their eye on and see if there are maybe additional ways to mitigate the potential for adverse selection in the markets. Further complicating this is that the IRS really does have their hands tied in enforcing this. They're not allowed to file liens or charge interest on the penalties for the individual mandate, and if an individual decides not to pay the penalty, they cannot impose fines or criminal charges for non-payment of that. So that is something that further complicates the situation. Dr. Lampier covered exchanges very well. I don't have a whole lot to add to that, just that the flexibility in the exchanges I think is very important. There are a lot of decisions that individual states can make, whether to negotiate premiums, what they're going to do with the relationship inside the exchange and outside the exchange, which can be very tricky, is also something that is very good about the legislation. Now, the timing for the exchanges is also a huge challenge for the states. And this is just something that a group has put out that suggests a timeline for how the exchanges will be implemented. 2014 is when the exchanges begin operation and policies sold through the exchange become effective. However, by January 1st of 2013, the Secretary of HHS has to certify in each state whether or not that state is on track to opening the exchange. Now, in order to meet that deadline, states really need to begin now or yesterday in getting this off the ground because they have to put administrative structures in place. They have to determine where that's going to be. Will it be in the Department of Insurance? Will it be in a quasi-governmental nonprofit organization, as Massachusetts has done? There are a lot of decisions there that need to be made. And then they need to begin the procurement process for all of those IT systems that Dr. Lampier discussed to allow states to have communication between the Medicaid agency and the exchange. But not only that, but between the exchange and the IRS. Between the exchange and the Department of Treasury in terms of collecting those subsidies for the low-income individuals. So this really is a very challenging implementation timeline that we are working for. Incidentally, a number of states that I've talked to believe that this timeline is in fact somewhat optimistic even. And that we may have to get things done quite a bit faster than that if we want to have some time to test the system before it actually goes into effect to make sure that it works. And finally, the Affordable Care Act begins the process of addressing some of the systemic costs that are driving health spending higher and higher at a seemingly inexorable rate. In the near term, it does put into place some cost savings with a new focus on prevention, which should over time begin to bend the cost curve somewhat, and also reducing some of the administrative costs. The medical loss ratio provision will begin doing that, but there are also some administrative simplification provisions that will begin reducing administrative costs, both for insurers but also for healthcare providers and in terms of electronic communications between the providers and the insurers to standardize that to some extent to reduce the administrative burden for some of the hospitals and physicians out there. It also creates a real myriad of pilot programs, everything from bundling of claims, accountable care organizations. It continues the implementation of health information technology, electronic health records that was begun under the stimulus bill, patient-centered medical homes. The list goes on and on. These are all, of course, pilot projects, and if they're successful, will need to be scaled up. But at this point, in order to avoid some of the unintended consequences that could arise under these really very significant shifts in the way healthcare is provided and paid for, we really need to take our time and learn from all of these pilot programs before trying to scale them up to the entire healthcare system. So with that, I'll just leave you with a quote from Winston Churchill after General Montgomery defeated Rommel in North Africa. Now is not the end, is not even the beginning of the end, but it is perhaps the end of the beginning. So thank you again, and I look forward to the discussion.